Very good.
Okay.
Okay, let's start reading the first case.
You are requested to see an 80-year-old man on the surgical service because of an elevated BUN and creatinine. He had just undergone a splenectomy for thrombocytopenia secondary to splenomegaly from underlying chronic lymphocytic leukemia. Immediately before surgery, his BUN was 22, creatinine was 1.3, and urinalysis was normal. When checked 2 days post-op, his BUN had increased to 40 and creatinine to 3.0, I would assume.
Yeah, 3.0.
Urine output for each of the last 2 days was approximately 250 milliliters a day.
Okay, so you call that kidney injury or kidney failure? How do we call it these days?
Was it
Acute kidney injury?
Acute kidney injury?
Yeah.
Does it looks like acute kidney injury, right? The guy came in, his urine output dropped. So remember, there is always a criteria of urine output, and there's always a criteria for creatinine for the definition of acute kidney injury. He's meeting both, and you know, every time I explain this concept of acute kidney injury, we have to understand that in nephrology we haven't really come up with a better marker than creatinine.
Is it okay to write on these?
Of course.
Okay.
This is for you.
Okay.
Yeah, so for the last 40 years, we've been pretty much making our decisions in terms of kidney function based on the creatinine value. You guys know what the creatinine is or where it comes from? It's a protein, right? And then that's one of the things that we ask patients when they have an elevated creatinine if they're taking creatine. You know, I don't know if you've seen that powder.
Muscle. Yeah.
Right. That can falsely elevate your creatinine, but and why do we use it to measure kidney function? Because it's freely filtered, and it's secreted, filtered and secreted a little bit by the proximal tubule, but it's not reabsorbed. So that's a perfect molecule, or near perfect. I wouldn't call it perfect because, like every other test in medicine, it has its pros and cons. But it's the best that we have for the last 40 years, and that's what we use to measure kidney function. And so in the BUN, it comes from the metabolism of urea. And as you guys know, if your kidneys are not filtering, that's one of the toxins that start building up. There's a bunch of other toxins that we can even measure, but BUN it's one of them, and it's easy to measure. It's cheap, but I also want to point out that not all the BUN, not all the elevations in BUN are consistent with kidney failure. And I just want to remind you guys that there are a few conditions like highly catabolic states. Like let's say you have a really bad burn, or you have an infection, a severe acute infection. Another scenario where the BUN may go up is when a patient is bleeding. I don't know if you've seen a GI bleeder in the hospital. If you pay attention to the creatinine, BUN creatinine ratio, these patients, they tend to have a pretty high BUN. And again, it's not necessarily related to renal failure, but I just want you to expand your differential. Every time you see a high BUN, it can be because the patient is catabolic. It can be because the patient is very dehydrated. So we call that, how do we call that in medicine when you're pretty dehydrated? We call that pre-renal, right?
Oh,
Pre-renal azotemia. Yeah. Azotemia is basically related to a high BUN. And we also see that in when someone is taking steroids. So if you pay attention to the labs and you have a patient that you're seeing here at the Cardiovascular Institute, and the patient is taking prednisone, take a look at the labs, take a look at the BUN, and invariably it's going to be high. So the bottom line is that the BUN, we use it, but we use it as a piece of information to come up with a differential diagnosis. You don't just use it, oh, because it's high, so this patient is pre-renal. No, the patient may be having a GI bleed, or maybe having a high catabolic state. Okay, so
is there a certain number for the creatinine that you're looking at, or is it like an elevation, or?
Excellent question. So the creatinine is a muscle protein, so we have to have that in mind when we make our interpretation. If you have a 75-year-old, very frail, elderly female with a creatinine of 1.5, that lady probably has a severe renal dysfunction. If you have the same individual, the same number with a totally different individual, like let's say a 35-year-old African American male with a lot of muscle, that's completely normal for that person. And that's where it comes down to understanding. Another example, the cirrhotic patient. If you give you a cirrhotic patient, a creatinine of 1.8, that patient is probably in renal failure. And why? Because they don't have muscle. If you pay attention to a cirrhotic patient, they have no muscle. So that's why it's important that we always interpret those things. The National Kidney Foundation came up with a classification, and you've probably heard of it, like stage 1 to stage 5 kidney disease. So that classification has been in place probably for the last 15 years. And the reason why they did it was to raise awareness on the non-nephrology providers to identify and to refer those patients to a nephrologist to work them up if necessary. I think that classification is good because it's simple, it's easy to remember, and you guys probably remember that stage 1 is the less severe, stage 5 is the most severe when the patient's GFR is less than 15. We call that stage 5. When the GFR is like 16 to 29, we call that stage 4. When it's 30 to 59, we call it stage 3. And 60 to 89, we call it stage 2, and greater than 90. You can still have kidney disease with a GFR greater than 90 if you have proteinuria or if you have any other abnormalities, structural abnormalities. But anyway, so the reason why I'm bringing it up, because today we're talking about acute kidney injury. I should probably change the name of this. It's not acute renal failure. It's acute kidney injury. We call it these days because it's a more descriptive way of putting it. And also the word renal failure is intimidating to the patients and the families. You feel like, oh, my kidneys are never going to come back. And we're going to learn today that some types of kidney injury are more, the prognosis is better than others. We're going to talk about that at the end. But the point that I'm trying to make is that those equations that came up with this classification from the National Kidney Foundation, they're useless in the setting of acute kidney injury. Why? Because the studies were done on very steady conditions, and it was a very large cohort of patients when they came up with this formula. I don't know if you heard about the DMRD, disease modified renal diet study. They looked into a large number of patients and they measured creatinines, and they also measure at the same time they did nuclear medicine studies to better assess the renal function, and they validated the DMRD equation as the standard of care to measure renal function or glomerular filtration rate. However, again, those equations were calculated on pretty steady conditions and pretty steady diet, because if you're a big meat eater, your creatinine is probably higher than a non-meat eater. So all of those things account. So for the purposes of this talk, we're not going to discuss GFR, because GFR, if a doctor tells you, oh, you're in kidney failure, and your GFR yesterday was 23 and now it's 15, that doesn't mean anything. What it means is like the creatinine in the setting of acute kidney injury. Okay? So what do you guys learn in the school about approaching a patient with kidney injury? What did it tell you? Did you ever hear about this pre-renal, intrinsic renal, post-renal? Okay, so I want you guys to do the exercise with me. And then let's go again to the first paragraph. And this is an old person that presumably he was relatively okay, creatinine at 1.3. He probably had a stage 3 kidney disease to begin with. But the UA was normal. And when they did it 2 days post-op, his urine output dropped and his BUN and creatinine went up. And so what do you think, if we go over the differential of pre-renal, intrinsic renal, and post-obstructive, how would you approach this patient? Like in other words, what other information? Let's say I'm sending you to see this patient. You're in the hospital, I'm your attending, I'm sending you, okay, I'm going to ask you to go see this person, and what kind of information is useful for me as a nephrologist. So the first thing we want to find out is like pre-renal. How can you become pre-renal? Either because you're bleeding profusely, right, decreased renal perfusion, or because they kept you NPO and these doctors, they were not careful enough to give you IV fluids. So you can definitely become pre-renal, but they're telling us a guy who underwent surgery, and if anything, these patients that go surgery, they always get a lot of fluid, and it's pretty unlikely. So is he bleeding? It's possible. So getting the hemoglobin, that probably rules it out. Also looking at the blood pressure chart, remember? The kidneys are very sensitive organs. In fact, when something goes wrong, the kidney is one of the first organs that actually take a hit. I'm going to give you an example, a surgical disaster, or sepsis, or shock. for many reasons. We have many different causes like cardiogenic shock, we have distributed shock, we have hypovolemic shock. So all of those things, they have an impact on renal function. So as a doctor in the hospital, you're obligated to find out what happened in this hospital. Let me review the chart. And even if you do a careful review of the chart, clinical studies show that in 50% of the cases, we can't even demonstrate hypotension, but the more likely cause of these patients' acute kidney injury is a hypotensive induced event. We call that ATN. Have you guys heard about ATN?
Yeah.
Acute?
Tubular necrosis.
Okay. How do you think they're going to ask you on the boards if the patient has acute tubular necrosis? Do you guys remember like the urine sediment? What does the urine sediment has? They love this question on your boards. They're probably going to get it.
Yeah, it's a certain type of cast.
Which one? Very good. So you're going to remember that is the muddy brown. Yeah,
and
muddy
that's
brown.
pre-renal?
No, that's
acute
ATN.
tubular necrosis.
You can go into
that's
ATN from a
intrinsic?
severe pre-renal state. You can develop
Okay.
ATN, but ATN is more like an intrinsic renal problem. And ATN can be caused for many different reasons, either because you became hypotensive or because the patient developed contrast-induced nephropathy. Have you guys heard about that entity? Contrast, iodine.
Mm-hmm.
Iodine can be toxic to some patients, not all patients, but some patients. Like the highest risk factor is if you're old, like this guy, or if you end up having diabetes with pre-existing kidney disease. Those patients are pretty high risk. There are 4 patients: old, diabetics with pre-existing kidney disease, and the patients that are either with an unoptimized volume status because they're either very dry or they're very wet, like a patient with decompensated heart failure. Those patients for sure they're at risk of developing contrast-induced nephropathy. And there is a fourth group of patients, which are patients with multiple myeloma. I'm sure you've heard about multiple myeloma. I'm going to give you some clues how to think about multiple myeloma on your boards because you're going to get tested on that. Okay, so, but again, the ultimate result on these patients is ATM. And on your boards, they're going to give you some sort of scenario where, this guy was taking the wrong medication or he became hypotensive, shock, whatever, and they're going to show you a picture of the urine sediment. And if you've never seen it, I recommend that you guys write it down and see it because you're going to get a question. Muddy brown cast is pathognomonic of acute tubular necrosis. And why does it look muddy? Well, the physiopathology behind this is that the patients, they have an ischemic injury to the tubules, and the nephron, which is the functional unit of the kidney, it stays relatively intact. I mean, it depends on the severity of the ATM, but in mild to moderate cases, usually the nephron is not involved, it's just the tubules. And there is a physiologic process of sloughing off the tubules. And that's why the patients may go from an oliguric or an uric phase. And if you take a look at the urine, I invite you guys when you go to the hospital, do rounds or everything, just take a look at the urine. The urine may look very dark, like mud. And if you were to take a sample of that urine, you centrifuge it, you put it in a slide, you take a look in the microscope, it's multiple casts from these dark pigmented color cells, and that's why it looks like mud on the microscope.
And it's from sloughing of the tubules.
From the sloughing of the tubules. So these patients actually, they tend to recover. Let's say God forbid something like this happens to you and I. Chances are we're going to recover because we don't have pre-existing kidney disease. But an old gentleman, or let's say a diabetic with pre-existing kidney disease, those guys can actually go into permanent renal failure, and we have to support them with dialysis. So the way I think about it is like they call you, you're the kidney doctor on call. They call you, you're gonna analyze this patient, you're gonna get good history from the record. You're gonna look for blood pressure because hypotension is one of the most common ones. You're gonna look for nephrotoxic medications. So which nephrotoxic medications do you guys remember? Which drugs can be very toxic to the kidney?
NSAIDs.
Very good. What else? Yeah, the FDA actually recommends against the use of NSAIDs in anybody greater than 60. It's just we become very susceptible to the toxicity, NSAID toxicity. Like you guys are too young for this, but in the 1980s, I'm sorry, 1990s, there was a big thing on the news with Vioxx, and a lot of people were like dying from like sudden death, and Vioxx was taken off the market with like multi-million-dollar lawsuits, and to this day we only have one selective COX-2 inhibitor, which is Celebrex, but a lot of doctors are scared to prescribe that because we know that they have significant toxicities, especially in the elderly, so don't prescribe that. Okay. Which other medications do you guys remember that we use in the hospital? I told you one.
Iodine.
The iodine. So it can be very toxic. I already told you 4 types of patients that can be at risk. Does that mean that we don't do contrast in those patients? No. We have some strategies to minimize the risk. For example, if the patient is dry, you hydrate them. If the patient is wet, you diurese them. If the patient is diabetic, we give mucomist, although some studies show that mucomist is kind of useless, but it's harmless. So it's a risk benefit, like everything in medicine. You always think about risk and benefits. So I always give it to the patients because I know I'm not going to harm the patient, and I may benefit them by using mucomist. But when it comes down to a life and death situation, for example, patient has a heart attack, diabetic kidney disease with protein in the urine, you know that they're likely to develop kidney injury. You just need to sit down with the patient and explain to them. Because if you go on dialysis, we can fix you. If you die from this, that's it. And then you have to, the heart takes precedence over the kidney. But you have to talk to the patients, and you need to inform them that that's one of the things that we're doing. Like the other day, I had a transplant patient that she had a massive retroperitoneal bleed. She had a kidney transplant. Massive retroperitoneal bleed. Her hemoglobin, by the time we found out, her hemoglobin was 2.8. And the kidney obviously stopped working. She went into what kind of kidney problem? ATN, right? Severe shock. She went into ATN, she stopped urinating, and the radiologist called me like, I have to give her contrast because they were gonna embolize. She was massively bleeding from some arteries, and it is what it is. So I just told the family, called his son, like, listen, mom needs it. There's nothing we can do. She needs it. So you deal with the consequences after. But contrast can be toxic. So what other medications do you guys remember can be toxic that we give to patients? There's plenty of medication. We don't use them very often, but like antibiotics, like aminoglycosides, like gentamicin. If you use it cautiously or you use it, you always, my advice to you guys is, when in doubt or you've never used it, just call the pharmacist because that's all they do. That's all they do. They take care of interactions. They take care of dosing. They know sometimes they're a little psychorigid because one thing is like being in the war zone and making decisions, and another thing is like being in a computer trying to advise physicians. And you have to negotiate with them. I always respect their opinions, but sometimes they're like, I feel very strong about this, and just negotiate with them. And for the most part, they always help you. But talk to the pharmacist because they're a useful resource, especially if you guys end up doing inpatient. I rely a lot on pharmacists, and especially when the patient is going to renal failure, one of the things we need to do is what? Renally dose all medications. Why? Because a lot of these medications, they're not necessarily toxic, but they build up, and they can cause serious side effects. For instance, if you have your patients on narcotics or your patient's taking tramadol, and the kidneys fail, and you keep giving tramadol, that patient is for sure going to become very, very confused, or is going to have a seizure. Who knows? So one of the musts when you have a patient with acute kidney injury is we need to renally dose all medications, and I rely on the pharmacist. So I call the pharmacist and I tell them, like, please adjust everything for me, and they do it very happily. Okay, so physical exam. Does physical exam help you figure it out, like what's the cause of your patient's kidney injury? Does it help?
Possibly.
I'm sorry?
Possibly,
yeah. Absolutely, yeah. Like today, with all the technology that we have, and we rely on labs, and we make a lot of our interpretations just by, when I get called with a consult, probably I would say 95% of the time I know what's going on without talking to the patients. But because you're trained to understand numbers and patterns, and once you've done this for a while, you realize like it's easier and easier to do it because you already know the patterns. But I'm gonna tell you something. If you want to be an excellent physician assistant, you have to listen to your patients. You have to understand what they're saying. Some doctors, they're not patients. Some doctors, they're just there because whatever, for whatever reason, but they don't listen to whatever the patient says. If you listen to your patients, you're likely to come up with the reason for the kidney failure. They may tell you, you know what, doctor, I haven't eaten anything for 5 days and I've been vomiting. You already know they're pretty renal. You don't even need to look at the numbers, you know. You already have a cause. Same thing, I'm having terrible diarrhea, or I've been using ibuprofen, like because I'm having this horrible pain. I've been using ibuprofen, 5 tablets a day, 800 milligrams each. You already know what's causing the problem. So talk to your patients. Physical exam wise, it's very helpful because volume status assessment. Have you guys done a little bit of volume assessment here? Like looking for edema or JVD? Yeah, so that's a skill that you guys need to develop, listening to the patient. So let's talk about that a little bit because that's also in the checklist that he sent me. Volume status. What are the things that you look for? Let's talk about a patient in CHF. What are the things that you look for?
So you're gonna look for peripheral edema.
Very good. Yeah. And what do you look for peripheral edema?
You can check in the legs. You can do hepatojugular.
Very
you
good.
can do JVD.
And in a patient that's been bedbound, and especially malnourished patients, they're very hypoalbuminemic. As you know, albumin is responsible for the oncotic pressure and keeping fluid inside. So look for the upper thighs and look for the sacral area. So I always, as a habit, I always bring the patient up and with my thumb, I press hard on the sacral area.
Right in the
that way, exactly. So that's an important aspect because if you have a bedbound patient, you may miss that if you don't do it.
Just looking for edema?
Looking for edema, like peripheral edema. So we look for, in severe edematous stage, you can see obvious signs like including facial, like a typical characteristic of the nephrotic patient, the renal patient, is that they have eyelid edema. They have anasarca. You can have anasarca from many different reasons, but one of them is renal. And the renal anasarca, these patients, they come up with eyelid edema. But you can also have anasarca from liver disease. I don't know if you've ever seen a cirrhotic patient, but these patients, they tend to have like edema all over. But on exam, they also have features of cirrhosis. You guys remember some of them? Features of cirrhosis, what are the things that you look for?
The spider veins.
Very good. Very good. What else do you look? Ascites.
Ascites.
The shifting dullness.
Is that the Medusa?
Medusa. Very good. And that has to do with estrogen metabolism. Larmy, look at the cricket.
Oh, he got away.
Oh wow.
Catch it. Maybe it has renal failure.
Yeah, he needs dialysis. No. And so.
He has renal failure.
So basically, those are the So I was telling you that the estrogens, they don't get metabolized, but they're metabolized in the liver. So if you have liver failure, these patients, they may have gynecomastia, and they can also have the telangiectasias. Yeah, and if you take a look at the breathing pattern, these patients, they develop like a respiratory alkalosis. They breathe very fast and very shallowly. Like you look at them and you do a blood gas, they have respiratory alkalosis. Okay, so volume status is very useful. So if you look at, let's put the opposite scenario. The patient is very dry. What are the things that you look for to assess like for dry?
Mucous membrane.
The mucous membranes, in kids, if you end up taking care of the kids, they cry. They can have, with no tears, they can have sunken eyes, they can have
skin tugging.
Skin tugging, very good. So all of those things are useful. So to answer the question that I asked, yes, it's very important. Physical exam can give you those things. So if you're examining an 83-year-old, what's common in 83-year-old males? Prostate problem,
PPH,
right?
yeah.
PPH. So you always do a good exam. You feel the bladder, and you can tell if somebody's retaining. I mean, most of the times they're very uncomfortable, but you guys are going to learn very quickly that diabetics are a box of surprise. They can present with MIs with no pain. I've had 2 patients with cholecystitis with no pain. I mean, that's unheard of in a non-diabetic. I mean,
why is that?
Nerve ending, nerve destruction, peripheral neuropathy. So those patients, they may not even be able to communicate, especially the elderly. They may get confused. So if you have an elderly person, always feel the bladder. Always. It's easy to, if you feel like they have we call that globus vesicalis, like urine retention, you can feel it, and you can tell right away. And how do you rule that out, by the way? How do you rule that out?
Obstruction?
Mm-hmm. What do you tell your nurse? What do you tell?
Okay.
So let's say I have the 83-year-old there, and then I want to rule out obstruction.
Like BPH obstruction?
BPH obstruction. What kind of test do you do? And you don't have an ultrasound machine.
Challenge?
No, because it's not going anywhere.
Yeah.
You already did your DRE?
You do a digital rectal exam, and yes, it's enlarged, but that doesn't rule it out. Prostate is enlarged. So what do? You don't have an ultrasound machine because that's the easy one. You just put an ultrasound and you say, oh yeah, there's a lot of urine there. What do you guys do? Just put a little catheter. You know, we call that an assessment of post-void residual assessment. So it's easy. You just advance it. You ask the patient to void. Most patients are able to void maybe a little bit. Some of them, they don't void anything. And then you ask the nurse to advance the catheter. If the patient has anything greater than 150, some textbooks says greater than 200, you have a patient with obstruction. And that may be the reason. And I always say maybe the reason is because you could very well have prerenal, intrinsic renal, and post-renal at the same time. You know, one doesn't exclude the other. In fact, most of the times in my business, acute kidney injury is multifactorial. And it's not just one cause, it's just a combination of different things. But it's easy to rule it out. In females, obviously, they don't have prostates, but they can also present with obstruction. Perfect example is the severe diabetic. They develop a pretty ominous complication of diabetes, which is diabetic peripheral neuropathy, and they can develop a neurogenic bladder. So that's why it's a must. If you're in the hospital and you need to rule that out, there's only one way of doing it, just put a catheter. If you don't want to torture the patient and you have the resource, just do a scan, a bladder scan.
Yeah, I already did.
You'll be able to tell. But diabetic, it's a must to do a bladder ultrasound because, again, it's quite common. And how do you treat these patients with neurogenic bladder? What's the treatment?
Catheterization.
It's horrible. If you think about it. Just imagine if you're a male or a female, whatever. For males it's a lot more uncomfortable, but a female is actually more embarrassing for them because they have to have somebody doing it for them. The males, they can still do it because the female won't be able to see the urethra, so it's always the partner, the husband, and it's very sad because they have to advance. Imagine like the violation of your privacy every single day. Like, they have to do it 4 or 5 times a day. Otherwise, they develop UTIs and then
do you just leave when you don't ever leave the catheter?
We don't
or
ever
the
leave the
bag?
catheter. No.
Because it'll develop, like a fomite?
The risk of leaving an indwelling Foley catheter is higher than doing CICs.
Okay.
Clean intermittent self-catheterization. That's called CIC. I don't know if you heard about CIC, but you know, for males, I'm sure you've seen those commercials like Medicare, Recover, those little things. So they send you the kit, and these guys they have to do it 4 times a day at least. I know most patients are not complying with that recommendation, but that's what the recommendation is, 4 times a day. It's pretty horrible. Think about diabetes as a horrible disease. Yeah, it's pretty bad. So that's how you rule it out, the post-obstructive, or if you have an ultrasound. But you can still be obstructed if you have nothing in your bladder. And the obstruction may be coming from the upper urinary tract, the ureters. So they may give you the classical scenario that they may give you on your boards. It's a female with cervical cancer. Fortunately, you guys live in an era where cervical cancer is less and less common. You know, my grandma died from cervical cancer. My mom used to tell me like she was only 6 when she lost her mom. But nowadays we don't see it very commonly because we do screening. And in the last 10 years, they came up with the HPV vaccine, and it's a disease that is getting eradicated, fortunately. But the classical scenario, if they ask you on your boards, for a female with cervical cancer or metastatic cervical cancer, they can present with acute kidney injury from obstruction, from bilateral ureteral obstruction. And those patients, they need, you know how they call them? Those tubes that we put in? Nephrostomy tubes, yeah. So those patients, to be able to help them. Otherwise, they go into dialysis, they go into kidney failure. So, yeah, or you can have, if you have a solitary functioning kidney and you have a kidney stone, you can present with dropped in the urine output, acute kidney injury, and it's easy to fix. You just call a urologist, they put a stent, they fix it. But you can also see this kind of scenario in bilateral kidney stones. Like for instance, patients with very high uric acid, they can end up developing. Hi.
Hello.
Hi. What's going on?
I want the prescription.
Is the pharmacy? Come over here. Let me see if they sent it.
So
No, what happened was I was away from.
yeah, so those patients can definitely develop
Explain to you. She needs.
bilateral kidney stones. Like tomorrow, we're probably going to talk about kidney stones because that's one of the topics. But you know, the composition of kidney stone can be anything. Can be uric acid, can be calcium, can be phosphate, can be struvite. But patients with bilateral kidney stones, they can be from uric acid, like high uric acid state. Like for instance, a patient with cancer. Have you guys heard about tumorlysis? Tumorlysis syndrome. So these patients can develop like severe hyperuricemia, and the hyperuricemia can form crystals, and sometimes they can form like obstruction. But that's part of the differential. So obstructive renal failure is less common, but still is part of the differential, and you have to rule it out. And it's simple to rule it out. Simple and cheap. That's how I call it. Simple and cheap. So to give you an idea of like the etiology of acute kidney injury, you're gonna think this way: ATN, 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 and maybe the rest. But you have to figure out why ATN, because ATN is the ultimate physiopath, but it doesn't explain the cause, because your patient may be bleeding, or your patient may be getting a nephrotoxic medicine, or your patient may be maybe having some sort of insult to the kidney that we need to identify the cause. But then there are other less common causes of kidney failure, kidney injury, and that's when we move into the intrinsic diseases of the kidney, which is a whole nephrology textbook. I'm actually gonna cover some of them later in the second case, but the point that I'm trying to make is that in the hospital setting, when you get consulted, it's probably likely related to ATN. And other things, of course, you have to think out of the box, but the chances of like having a rapidly progressive glomerulonephritis are pretty minimal in-house, you know what I mean? And it's almost always that we did to the patient. If you pay attention to the patients that go in the hospital with normal kidney function and they end up developing worsening kidney function in-house, the answer is in go back, review the chart, see what we've done for this person, blood pressure wise, medication wise, and you're gonna be able to tell whether or not, you know, what the cause of the kidney injury is. Okay? Alright, why don't you go ahead and read the second paragraph then.
The patient denies symptoms of congestive heart failure. He has not been extremely thirsty over the last several days. He has had difficulty urinating over the past several years with a weak stream and nocturia 3 to 4 times per night. His doctor told him he had BPH, but no therapy was given. The patient denies leg pain or flank pain. The hospital chart is reviewed, which showed the patient had significant bleeding in the preoperative period, with several episodes of hypotension with systolic blood pressure in the 80 range.
Just benazepam?
This episode lasted for short periods of time, less than 5 minutes, and returned to normal blood pressure after that period. His urine output was 700 milliliters a day immediately after surgery and dropped to 200 to 300 milliliters a day over the past 2 days.
That's pretty little, right?
Yeah.
You guys know what the normal urine output is?
8 milligrams.
1.5.
1500.
Yeah, like depends on the fluid intake, but probably I would say no less than 1 liter, and definitely can be even over 2 liters. But this patient is definitely oliguric.
Let's see here. For the 3 days after surgery, his total fluid balance is positive 3 liters. His only medication post-operatively was analgesia with Dilaudid. He did receive 1 dose of cephalothin preoperatively and none since that time.
Cephalosporin is a first-generation cephalosporin. That's what we do for antibiotic prophylaxis. Yeah. Yeah. So yeah, most surgeons do, and there's only one time dose. Okay, so very good. So I gave you a lot of information there. Does that historical information affect your differential?
Exactly.
Okay, is it possible that he may be obstructed, like he has like prostatism? It's possible, right? He's an old dude and he had like nocturia, which is pretty common, by the way. What do you recommend your patients with nocturia, by the way? How do you make their lives easier? So you give them simple advice. You tell them drink less, nocturnal fluid intake. You know, nothing after 5 p.m. I mean, it's pretty hard to follow that recommendation, but you know, it's your quality of sleep, right? And less caffeine. That also helps. Okay, so what is your more likely diagnosis at this point? After the things that you reviewed.
Combination of prerenal and postrenal.
Why prerenal?
The bleeding and hypotensive during surgery.
That would be ATN then.
Oh, that's ATN.
That's intrinsic renal.
Oh.
ATN. Prerenal is more like having diarrhea, nausea, vomiting. I go in the hospital, they give me IV fluids, and my kidneys are fixed.
Oh.
Whereas ATN is more like there's some damage sustained to the tubules.
Okay.
And the recovery process may take days to weeks, or may not even happen.
How do you know that the bleeding is in the tubules and not, because you said pre-renal was decrease in perfusion, so maybe it's bleeding somewhere else, or like...
Yeah, no, invariably patients with patient bleeding, invariably they become pre-renal because they get less renal perfusion. But when that's a sustained state, like in other words, like it happens over a period of hours, can be severe enough to cause a more severe degree of kidney impairment, which is ATN.
Gotcha.
So most patients bleeding, vomiting, they may have some pre-renal component, but if you combine that in addition to the hypotension, I'm pretty sure those kidneys, they had an ischemic injury, ATN.
Gotcha.
So this is
acute bleeding is pre-renal, sustained bleeding is ATN?
Yeah, I would think like if they mention the word bleeding, think about ATN. Because the bleeding is not going to turn around very quickly. You know, by the time the patients are diagnosed and treated, the kidneys are very sensitive organs. We have to remember that after this talk. Sensitive organs. Whenever some sepsis, SIRS, the kidneys are one of the first ones that go down, and they respond also very quickly, depending on the severity and the duration of the insult. Okay. So.
And you got an analgesia.
But what kind of analgesic is that?
Well, it says with dilaudid, so I don't know if could it just be an opiate, or is it an analgesia like NSAID?
Yeah, they only gave him an opiate. So the opiate doesn't cause acute kidney injury.
But it could build up.
It could build up. That's the thing. So that's why you have to be smart, because these events are evolving as we speak, and then the patient's clinical status depends on the interventions that you take. So whenever it becomes part of your thinking. Like every time I have a patient with kidney injury, the first thing I do before I sign off, I review the medications and I say like this needs to come out, this needs to come out. Just part of the care of these patients. Okay, go ahead, Mario, read the third paragraph for me.
The patient's physical exam showed temperature of 37 degrees Celsius, respiratory rate of 14, blood pressure 130/90, pulse rate of 82, with no orthostatic changes. His mucous membranes were moist. Neck pains were 1 centimeter above the sternal angle. The patient's lung exam was clear auscultation and percussion without rales. Cardiac exam has a normal S1, S2 without S3 or murmurs appreciated. The patient's abdomen was soft with slight tenderness over the surgical scar. No ecchymosis were noted. The patient had no CVA tenderness or ecchymosis present in the back. A Foley cath was placed in the patient at that time, which showed approximately 50 cc's of urine in the patient's bladder.
Okay, so how does this physical exam help you determining the cause of the acute kidney injury?
What is neck pains? What is that?
Its neck pains are 1 centimeter above the sternal angle.
Underneath the temperature and respiratory. Neck pains were 1 centimeter. What is that?
Oh, no. What I meant to say was the
neck veins.
The neck veins. That's what I meant to say. So he's not volume overloaded, right?
Right.
That's what I mean. And then.
And he's not dehydrated.
Yeah, he's not dehydrated. and he's not obstructed, right? Because you
Right.
measure,
It's only 50.
we talked about 150 or greater than 150. Some urologists it's not even 200, it's 250. But anyway, as a nephrologist, anytime I see 150, that's to me that's retention. So I already told you on physical exam, I already told you that he's not pre-renal. I'm sorry, he's not post-renal, he's not volume overloaded.
Right.
Yeah.
Thank you.
So basically,
So it's ATN.
yeah,
Yeah.
it's pretty much like I said, ATN,
Yeah.
and then we're gonna talk about another cause in a minute. So go ahead, Carrie again, Carrie,
Kelly?
Kelly. Sorry.
Alright, a fresh specimen of the patient's urine is examined under the microscope and showed numerous epithelial cells and brown degenerating cellular cast. No crystals or white blood cells were noted and only rare RBCs were present. The urine sodium was 40, urine specific gravity 1.01, repeat BUN and creatinine on the 4th day after surgery were 52 for BUN and 3.5 for creatinine. Uric acid was 9.2. A renal ultrasound is done. Kidneys are normal in size and no signs of obstruction present.
Okay. So he's getting worse, right, Kelly? Look at his numbers.
BUN went from 40 up to 52, so it's increasing, and creatinine also. Yeah,
And
so
we're talking about day 4th, right?
the 4th day?
Yeah.
Right.
The first one was how many days after? 2 days
2 days after.
Yeah. So he's getting worse, and then this guy's making little urine, right? We talked about like a normal urine output, and he only made like 200 and 300. That's pretty negligible, right? So do you want to keep giving him fluids? Do you think fluids are going to help him?
No.
Yeah, but you know, having said that, most doctors, they keep giving fluids to these patients like if the fluids are going to help in any way. And they've done many studies and it doesn't help. In fact, if you don't pay attention to the volume status, you're doing a disservice to your patient, because at the end, you're probably going to end up accelerating the dialysis initiation. And is there a magic pill for ATN, by the way? Or is there a magic treatment for ATN? No, it's supportive care. Supportive care means avoiding hypotension, avoiding nephrotoxins, and avoiding, you know, like the volume complications of kidney failure. If you keep giving this guy like 100 cc's or 150 cc's an hour for 4 days, he's already volume positive. You told me 3 liters, right?
3 plus.
So you better stop those IV fluids, otherwise the guy's gonna start like breathing funny, and you're gonna end up putting like cold glue to intubate the patient and put him on dialysis. So yeah, so basically this guy, we all agree that he's going into ATN. The renal ultrasound, why do we do a renal ultrasound in renal failure, guys? What's the purpose of doing a renal ultrasound?
Looking for obstruction, right?
Yeah,
So it's a-
structural
it's a-
abnormalities of the kidney, and 95% of the times hydronephrosis,
Yeah.
whether or not the patient has hydro. Does it happen very often? No. Again, most common is prerenal and ATN. That's the two most common causes of kidney injury. Prerenal, it resolves very quickly. ATN, it takes days to weeks, sometimes months, and sometimes it never happens. But that's basically the difference.
What's a normal uric acid level?
Less than 6.8, less than 7. So this person also has high uric acid. And why is that happening?
The Tumorlysis syndrome.
It can happen in many things. It can happen in Tumorlysis syndrome. It can happen in kidney disease because the uric acid is cleared by the kidneys. It can happen in leukemias. It can happen in patients with gout. I'm sure you're going to see a lot of gout. So if you have a patient with gout coming to you and you don't have labs, make sure you check labs, because you don't know what's first, the chicken or the egg. It may be the kidney disease leading to gout. And if the patient hasn't had any labs, please don't give him NSAIDs, because you may be giving NSAIDs to somebody who's already in kidney failure.
So somebody with gout, does that predispose them to
have kidney disease?
Yes.
I'm sorry. Somebody with kidney disease is predisposed to have gout.
But not the other way around.
Very high uric acid can cause kidney injury, but it's not as commonly seen.
Okay.
Yeah, so you can have acute. There's 2 types of kidney disease associated with high uric acid. One is called acute uric acid nephropathy, which is what we were just discussing about deposition of crystals in obstructive ATN. And there is another way of injuring the kidney, which is called chronic uric acid nephropathy, and that's not a common entity. And in fact, we don't really understand the prevalence of that entity because it's so common to have elevated uric acid that we don't biopsy patients with high uric acid and kidney disease because we assume it's probably the kidney disease causing the hyperuricemia and not the opposite.
So do you give them allopurinol?
We give them allopurinol or Ularic, or we give them, there's a pretty powerful medications these days to bring down the uric acid very quickly. But for the most part, most patients, they get very well controlled with allopurinol.
Okay.
Yeah. Okay, let me see.
And then, but for their pain, usually we would give them indomethacin, but they can't. Exactly.
That's why I want you to check labs. If your patient if you don't check labs, let's say this patient comes in with gout, very classic gout like podagra, pretty guy in a lot of pain, you don't have any labs and you're prescribing indomethacin, that's malpractice.
Yeah.
You have to check labs because how are you going to give indomethacin? In other words, you're just treating a symptom. That's what pharmacists do or people without any medical knowledge do. They just give medications to alleviate pain without getting a diagnosis. So you have to check labs. If you don't have labs on somebody with gout, that's just not good.
And then you'd order in the prescription or whatever
afterwards.
Yeah.
You can manage the pain with opiates. Like if you work in the urgent care setting, there are some medications that are urgent care friendly. Like for instance, amlodipine if you have high blood pressure. It's pretty harmless. You don't need to know the labs before or after. But if you're going to prescribe an ACE inhibitor or a thiazide or a loop diuretic, you need to have labs. It's a must. If you prescribe without labs, it's on you. If something happens, it's on you because the patient is going to come with a sodium of 105 and they're going to tell why didn't you check labs? It's just common sense. But having said that, the opiates are pretty urgent care friendly because they're not, other ramifications of prescribing opiates because we have a lot of people going to urgent care. But you're going to be required to sign up for Cures, what's the name of that thing? Cures, which is the database in the state of California, where you can, in less than a minute, you can actually verify somebody's prescription history, opiate prescription history. So that's also helping a lot of eliminate a lot of the abuse that we see in the urgent cares. But opiates, for instance, for management of pain is very good. You don't want to have your pain waiting for an hour for those labs. Just give them a little bit of something, an opiate or something. And if they truly have gout and they have kidney disease, you don't give NSAIDs. The treatment of choice is steroids, prednisone. They respond very well. If it's truly gout, if you give them prednisone, something like 20 milligrams a day for 5 days, that's sufficient to control the gout pain. If you don't want to use steroids because whatever the patient is diabetic or he's declining, you can use colchicine, which is very effective as well. In fact, if he doesn't respond to colchicine, you may want to reconsider your diagnosis because you may be dealing with something else and not gout. And for long term, you use allopurinol and one of these medications to control uric acid.
Hello, how are you?
Okay.
That's okay.
Okay, so we talked about how we're going to treat him, and then on day 6, what do you go ahead, Mario?
Sure. On day 6 after surgery, the patient's BUN is 68, creatinine is 4.1. His urinary volumes are between 300 to 500 mils per day. Serum electrolytes are sodium 142, potassium 4.2, chloride 98, bicarb 23. The patient is started on fluid and salt restriction, but he remains oliguric. By day 8, the patient's BUN is 85, creatinine 6.3.
Sure. We'll see what we can do.
Okay. Is there anything else you would do to manage this patient at this point? He's getting clearly worse, right?
You're welcome.
I refer to you.
I would have done that probably on day 4, maybe day 2.
So, but my question to you guys is, when do you start dialysis?
Yeah, that's what I was gonna ask.
Right.
So is there a number or there's a magic thing for dialysis? What do you guys think?
And how the patient's doing?
What was that?
Because I'm assuming each patient would be different on
Very
when they
good,
start.
yeah. Each patient will be different and each doctor will make different decisions. Some of them will be poor, some of them will be great. So the point that I want to make is that they teach us that there are some indications for dialysis, but you can make that decision without seeing the patient because it's actually a decision that you make after you review the labs, you review the urine output. If this patient is already picking up a little bit, He's going 300 now. They said 500. That means that he's making a little bit more urine. If you don't see an increase in the urine output, your patient is in trouble, right? So that every day is very important that you get accurate isonos. That's one of the reasons why we follow, we put fluids in these patients to make sure we account for every drop of urine. But also you want to take a look at the labs. If the labs are fine, if your patient has pretty normal labs, there's really no rush to start someone on dialysis, because we all get taught in medical school that you think about hyperkalemia. That's one of the most serious complications of acute kidney injury. But you also think about metabolic acidosis, to the point that these patients are getting tired. They're breathing. The lungs try to compensate for the metabolic acidosis by blowing out. By retaining the CO2, and by blowing out the CO2. So these patients, they end up, that's an indication for dialysis when they're already having like compromising the mental status, or when they're going into respiratory failure. Very clearly you need to put this patient on dialysis. But I'm giving you pretty normal labs on this individual. I told you that bicarbonate is 23, that's normal. I'm giving you a potassium of 4.2, that's probably better than mine. And sodium is okay, and he's making some urine, he's not in respiratory distress, so there's no need to put him on dialysis unless you have some financial interest in doing that. So obviously you can, in these days where you see a lot of pressure from discharge planners and the hospitals, you go in and say, hey doctor, when are you going to send this patient out? So I'll tell you something about this patient. I wouldn't send the patient home with a rising creatinine. Why? Because you don't know. Probably chances are he's going to turn around, but what if he doesn't? And you're not checking daily labs, so you're not able to make decisions. So the decision about starting someone on dialysis is a daily assessment of the volume status, the urine output, and the electrolytes. And obviously the patient's preference. Sometimes the patients tell you that there's no way I will take dialysis. That's enough to write it off. And then just try to manage the patients. But again, I already told you guys, there's no magic pill. Right? I explained this to you. It's just supportive care and your own ability to heal and get rid of the renal failure. Okay, go ahead, Sarah. On day 9.
Okay, on day 9, post-operatively, the patient's urine output begins to rise to 1 liter per day, and by day 11 it is up to 3.5 liters per day. The patient's BUN is up to 92. Creatinine 6.9 on day 11.
Okay, so what is notable in this paragraph? He's peeing, right?
Yeah.
So
but it's a lot.
A lot, so it's great. Actually, this guy is like getting rid of all that IV fluids that they kept giving him for 4 days before somebody said like, oh, this guy's gonna stop breathing. So he was positive 4 liters, so that fluid needs to come out. So that's one of the complications of ATN, and it's called post-ATN diuresis. So the post-ATN diuresis can cause 2 things. It can cause 3 things. It can cause hypomagnesemia, hypokalemia, and hypovolemia when they're peeing a lot. But my general rule, if your patients are eating and drinking, let them be. The body will tell, his brain or her brain will tell how much they want, how much they need. So
you said hypomagnesemia, hypokalemia,
or like they become hypovolemic, like they urinate a lot. But again, if your patient is bedbound, I try to match them or I try to support them. But my preference is always just let them fly. Why? Because I need to know when it's safe for me to send this patient out. If he's peeing 5 liters and I'm giving them 5 liters, I don't know. How am I gonna know? The only way of knowing it is just let it be. Cut it down, have the patient eat and drink, and if they're holding on to the electrolytes and the volume status, they're good to go.
Let him be, as in stop giving him the IV fluid?
Yeah, I don't give IV fluids if they're eating or drinking. In fact, if the patient stops peeing, you need to take those IV fluids off because you're only causing harm. Okay, why don't you read the last one? On day 12?
Yeah. Let's see. On day 12, the patient's urine output begins to decrease to 1.5 liters per day. His BUN and creatinine begin to fall. Fluid and salt restrictions are discontinued. The patient is discharged from the hospital on day 14 and followed up as an outpatient. His BUN and creatinine returned to normal 3 weeks after surgery.
Okay. So that last paragraph explains the natural course of ATN. Most patients have a favorable prognosis. Some patients, especially the ones with pre-existing kidney disease or they have multiple comorbidities, they won't recover. But for the most part, most patients go to the previous renal function that they had. But some other patients, they may be left with residual damage, and that residual damage may be permanent, not necessarily something that you can bring back. Okay. Any questions?
If you needed to start dialysis, is that any prognostic factor for
recovery of the kidney function? Excellent question. Yeah, they've done some studies, and some studies suggest that patients with dialysis, they have a delayed recovery of the renal function. But in general, every nephrologist has a different way of approaching it. The safest thing to do is just to make sure your patient's electrolytes are stable, your patient's volume status is stable, and if they need it, they need it. You know, it also depends on how you prescribe dialysis, because some patients, like everything else, like you probably heard that dialysis patients are crazy. I don't think they're crazy, it's just a lot of the non-compliant people end up on dialysis. So that gives you a falsely elevated prevalence of mental disease in the dialysis units. It's just the non-compliant, just common sense, right? If you don't listen, you're going to end up on dialysis. And that happens with a lot of the diabetics. So at the same time, when you start someone on dialysis, I teach them that I need their help to be able to do well on dialysis. I'm going to give you an example. Dialysis patients, they have they have to adhere to a sodium and a fluid restricted diet. Some patients, they feel because they're already on dialysis, I'm going to eat whatever. It doesn't work that way. Why? Because if you gain a lot of weight in between your treatments, most patients on dialysis, they stop urinating after a while. It can be months, it can be years, but universally, most patients, they stop peeing at one point. So if you understand that concept, you understand that you're 100% dependent on the dialysis machine. So if you still pee and you want to preserve your residual kidney function, the best thing you can do is to keep it simple from the fluid perspective and from the sodium perspective. Why? Because when I start using the ultrafiltration feature from the dialysis equipment, I'm harming your kidney, your residual kidney function. And this is an important concept that I always emphasize to students. Being a dialysis patient doesn't mean that you don't have residual kidney function. And they've done many studies, and those are the patients that do well. If you have residual kidney function, you enjoy from better quality of life, because it's common sense that if I still pee, I can drink, right? Or a little bit more. If I don't pee, there's so much I can drink. You know, the recommendation for anuric patients is 1 liter in a 24-hour period. And that's pretty little. I mean, it's like 2 bottles, right? So most patients are having a hard time adjusting to that recommendation. But if you want to do well on dialysis, you need to do that. Otherwise, I have to use the machine to remove a lot of the fluid, and that ultrafiltration kills the residual kidney function. So by the same token, if you have residual kidney function, you enjoy, I already told you, better quality of life, better phosphorus control because the nephrons are still functioning. The secondary hyperparathyroidism, which is one of the renal complications, is not as severe in patients that they still urinate. And survival. You know, many studies have shown that dialysis patients that urinate, they have a much lower mortality rate. So sometimes the patients don't listen. Even if you tell them all these facts and you give them studies and everything, they do whatever. I recently lost a patient. She was gaining, which is ridiculous, a very obese woman. She was gaining between 10 to 11 kilograms in between her treatments, where the recommendation is to gain no more than 2 kilograms. She was exceeding that recommendation by 5-6 times. She died. She died suddenly, and that's what happens. Patients that don't adhere to fluid restriction, they do very poorly. So they feel like, oh, dialysis is going to fix my life. You have to realize, guys, that the kidneys work 24/7. And it's a pretty impressive job, because you have a calculator there? Just tell you. So just how many minutes do we have in a 24-hour period? We have like 1480, right? let's say that 1480, you're gonna multiply that by 100. Let's say that a normal renal function 100 mL per minute. So you have 148 liters of blood flowing in a 24-hour period. That's like 50 gallons of blood flowing in the kidneys in a 24-hour period. If you think about that, dialysis only gives you 3 to 4 hours 3 times a week, and very suboptimal. So when we put up someone on dialysis, it's the equivalent of a patient that's gonna die. We put them on stage 5, and he's gonna be able to live. But the point that I'm trying to make is a very suboptimal way of living, because we don't get even close to the level of efficiency and functionality that a human kidney has. So dialysis is very suboptimal. So patients, I always explain that concept to them so they understand early on in the game that if you don't listen, you're not gonna do well. And when you hear about like, oh, dialysis patients are crazy, again, it's because they end up there very commonly compared to the good listeners. Okay? Very good. We have another case. What time is it? 5. Okay. Okay, here's one.
Thank you.
Thank you. Why don't you go ahead and read the first half.
Me?
Uh-huh.
Okay. 49-year-old man has come to your office with the complaint of swelling of his body over the past several months. He states that approximately 3 months prior to admission, he had fallen off his bike and bruised his right leg. He noted swelling in the leg at the time, and soon thereafter noted both his legs had become swollen. Over the past several months, he noticed the swelling had increased over his entire body. He reports 20-pound weight gain over that period of time.
So what are the probable causes of total body edema in a patient? What do you guys know about total body edema? We also call that Tarzana Ca, right?
NCHF.
Very good. What else?
Nephrotic syndrome.
Nephrotic syndrome. Very good. What else? Otherwise I wouldn't be here. I'm just kidding. What else? Liver failure, cirrhosis, yeah. So malnutrition, right? Or malabsorption. But there's some other states, like severe hypothyroidism. Do you guys remember the mixed edema?
Oh, mixed edema.
They give you like a non-peeling edema. So that's another entity in the differential of total body edema. So the easy way to remember is heart, liver, kidney, severe hypothyroidism, malnutrition, and then we have differential like unilateral from a DVT or from some sort of severe thrombosis, but for the most part you're pretty much covered with those 4 entities. Okay, and all right, why don't you read the second paragraph? Sorry.
Okay. He has no history of heart disease and denies PND, DOE, or orthopnea. He has no history of liver disease and denies a history of jaundice, dark urine, or alcohol use. He does not know of any exposure to any hepatitis and has no history of IV drug use. He was never told of any problem with his kidney as an adult or a child. His urine frequency is unchanged over the past 2 months.
So, given this patient's history, is the likelihood of congestive heart failure or cirrhosis there, or what do you guys think?
No.
Because I already told you, like PND, DOE, and orthopnea are very classic signs of heart failure.
What's PND?
Paroxysmal nocturnal dyspnea. It's patients that they wake up in the middle of the night, short of breath, and they open the window. That's a sign of uncompensated heart failure. So you can enjoy your patient here and ask them that question. Do you wake up in the middle of the night gasping for air or like having to open the window for air?
Yes.
PND. Okay, so, and I already told you that, yeah, he doesn't have really anything consistent with liver disease, right? No jaundice, no alcohol use, no hepatotoxins.
No.
Okay, so what physical exam points should be focused on this patient. So for your boards, if they have hypothyroidism, it's non-pitting edema. If they have malnutrition, you can see other signs of, malnutrition, temporal wasting, muscle atrophy, some sort of malabsorption or some sort of they give you some history of malabsorption, right, or some sort of malnutrition. For heart failure, I think we discussed it with the other case, volume status. You can also hear an S3 gallop in these patients when there's heart. Hepatic dysfunction, we kind of cover everything already. And nephrotic syndrome. So you can see nephrotic syndrome. So go ahead, Mario, read the third paragraph.
On physical exam, he appeared grossly edematous and puffy. His vitals, blood pressure 145/98, pulse 92, respiration 16, temperature 98.6. The patient's skin shows no signs of jaundice or telangiectasias. He has no signs of palmar erythema. His face shows swollen eyelids, but sclera are non-icteric. Examination of the neck shows no signs of JVD and no thyromegaly. His lung exams are clear to auscultation and percussion, with the exception of decreased breath sounds and dullness to percussion in the bases. Cardiac exam reveals a non-displaced PMI, normal S1, S2, no murmurs, rubs, S3 or S4. Abdominal exam shows the liver to be approximately 9 centimeters in size. No splenomegaly was appreciated. There were findings of shifting dullness to percussion of the abdomen. In the periphery, the patient had 4+ pitting edema to the level of the sacrum and throughout both legs. The patient had no signs of gynecomastia, testicular atrophy, or parotid swelling. The patient's neurological exam was normal.
Okay, does it sound like CHF? Do you see any cirrhosis on the things that they describe? They mentioned somewhere somewhere they said that he has a shifting dullness.
Yes.
Can you see that in other states other than liver disease?
Yeah, it just means fluid.
Yeah, so you can have nephrogenic ascites and you can have cardiogenic ascites. It's just a sign of ascites, but ascites is not pathognomonic of liver disease. So you just have to investigate the reason of the ascites, and that's why we tap these patients to try to identify why they're having this. Okay, so what aspects of this physical exam that Mario read that may be consistent with nephrotic syndrome?
Swollen eyelids.
Swollen eyelids, very good. High blood pressure. Heart failure gives you the opposite, right? Very low blood pressure. What else? Pleural effusions, actually. See, the edema can be, non-specific, but these patients with severe nephrotic syndromes, they tend to have a lot of pleural effusions. So that's probably one of the reasons of these guys. And I'm sorry?
Fluid at the base of the lungs.
The fluid in your lungs.
Right.
Yeah. On the exam. And the swelling eyelids, like I told you, is frequently seen in patients with nephrotic syndrome.
Is scrotal swelling too? Is that because it's all dependent areas? Or?
You can see, that's another good point, examine the patient's genitals, because there's another area where you can have a lot of fluid buildup. Okay, so what kind of tests do you order to confirm the diagnosis? A UA, very good. So I cannot tell you how many times I've been consulted to see a kidney patient with no UA. Would you call Dr. Ben-Zur without an EKG to see one of your cardiology patients? So why would you call a nephrologist without a UA? So always remember, if you're going to call a consult, and just make sure you do a UA. Okay, so why don't you go ahead, Kelly, and read the next.
A urinalysis revealed 4+ proteinuria with a microscopic exam that revealed several waxy casts, oval fat bodies, no cellular casts, 1 RBC and 1 WPC per high-powered field. Electrolytes included BUN of 20, creatinine 1.3, other electrolytes, glucose, calcium, phosphorus were normal. 24-hour urine collection showed 12 grams protein and a creatinine clearance of 72 milliliters per minute. LFTs are normal, as was prothrombin time. The patient's albumin was 1.9 and serum cholesterol 670. Chest X-rays revealed bilateral pleural effusions without signs of pulmonary venous engorgement or abnormalities in the cardiac silhouette.
So what's the diagnosis?
Nephrotic syndrome.
And what is nephrotic syndrome?
They get the hyperlipids, right?
Yeah, proteinuria.
And what is the differential for nephrotic syndrome? Remember, it's a syndrome. I mean, we have to put in a name and a last name, right? It's like you're telling me your patient has a fever, okay? Fever, and what's the cause of the fever? Same thing with nephrotic syndrome. You're giving me the name of a group of features that can be multifactorial, but we all agree that this is renal in origin, right? And do you guys remember some of the differential diagnoses for nephrotic syndrome?
I remember nephrotic.
IgA.
IgA is more nephritic.
Yeah, it's all nephrotic.
Oh, that is different.
Yeah. So it came down with this classification. Somebody did it. Honestly, one of my attendings used to say that this British nephrologist came up with this classification that's not very useful when you think about the way you manage these patients, because nowadays we biopsy these patients. We do a biopsy and we can actually accurately have a name and a last name for these abnormalities. But back in the days, they were dividing them up based on similarities, like massive amounts of protein in the urine, lip disturbances, bland urine sediment, because somebody read that it was only 3 WBCs, or 1 WBC and 1 RBC. That's pretty bland. In other words, it's not nephritic. So those patients, he called them nephrotic, and he also made this requirement of having like more than 3.5 grams of protein in the urine. Honestly, that classification to me is useless, but if it makes it easier for you guys to remember, I think that's probably why it stayed over the years, and we still teach it in med schools about these nephrotic and nephritic. But yeah, so there's many different causes of nephrotic syndrome. You guys remember? What's the most common cause?
Diabetes.
There you go, thank you. Diabetes by far is 50% of the etiology of kidney failure in the world. Diabetic kidney disease is definitely something that we have to rule out. We don't biopsy every patient with diabetes if it's very obvious that they've been diabetics, poorly controlled for a long time, and they present with a lot of proteinuria. We just have to assume that it's diabetic renal disease. And what's the prognosis for those patients? It's pretty bad, actually. It's very sad because every time I meet a diabetic with this degree of protein and evidence of diabetic end organ damage, I mean by that diabetic retinopathy or diabetic peripheral neuropathy or diabetic gastroparesis, you name it, these patients, I don't biopsy them because it does not going to change my management. Hey, listen, how are you? It's not going to change my management, number one. And number two, invariably they're going to end up on dialysis. So it's pretty bad.
So when you get trace protein in a diabetic, should you be concerned for possible
progression?
Nephrotic syndrome.
That's the first abnormality. You can stop that. That's why we use ACE inhibitors.
Right.
And that's basically perfect glycemic control, perfect blood pressure control. But once the patients have full-blown nephrotic syndrome, diabetic nephrotic syndrome,
there's no going
so
back.
much you can do. You can perhaps delay the progression of renal disease, but your patient is likely to become dialysis dependent or require a kidney transplant.
And then when you get the trace, are they required to be on the ACE or the ARB indefinitely, or until that?
As long as they're able to tolerate it. One of the problems with ACE is that it can give you hyperkalemia or cough. Yeah, and so as the kidney disease progresses, then it becomes a little problematic because the patients start having hyperkalemia, and then it gets to the point that you need to drop it. But for as long as you can tolerate it, and as soon as they become dialysis dependent, we give them back to them because it protects residual kidney function.
Okay.
Yeah. Let me just get some water. They have water in the back, right?
Yeah.
And in that
room
little
9,
room?
I think.
Room 9? Okay. I'm gonna get some. I'll be back.
Okay.
Diabetes that cause minimal change disease.
Minimal change disease. You're cheating.
I know, I was just trying to get
So we call it
I don't even know what that is.
Nils disease. Have you heard about Nils disease?
Heard it, but I don't know.
That's the same as minimal change disease. And we call it Mills disease because it comes from nothing in light microscopy. In other words, all these changes are ultra structural changes that can only be seen in electron microscopy. So yes, it's the most common cause of nephrotic syndrome in children. And in adults, is associated with what kind of lymphoma? I remember? Non-Hodgkin's lymphoma. So whenever you have a patient with minimal change disease in adult, with this diagnosis, you're kind of obligated to rule out lymphoma. There's a disease association. So that's these patients, they present with massive proteinuria. It can be recurrent and relapsing.
So the most common cause of nephrotic syndrome in children is minimal change disease.
In adults, it's not the most common cause.
Right. So
and when you see it in an adult, you're obligated to rule out lymphoma.
Okay. So when you see minimal change in an adult, you need to look for lymphoma.
Yeah. So what other do you guys remember? Membranous. Remember membranous nephropathy?
Could that cause both nephritic and nephrotic?
It can cause, membranous can cause, no, membranous is nephrotic.
Okay, nephrotic.
Yeah, membranous is nephrotic by definition. And the most common disease association is hepatitis B. So they may ask you that on the boards. If you have a patient with Hep B, they can develop secondary membranous. So there is idiopathic membranous and secondary membranous. The cause of secondary membranous is the differential is pretty broad. We have, let me tell you, we have like NSAIDs can cause minimal change and it can also cause membranous. Captopril, which is an ACE inhibitor, can cause membranous, secondary membranous. Plavix can cause secondary membranous. Some infectious diseases like syphilis or malaria can cause membranous. Some pretty old-fashioned rheumatologic drugs like gold, penicillamine, those medications can cause membranous. So the differential is pretty broad, but the most common, the one that they love to ask on your boards is hepatitis B and secondary membranous.
As other causes of nephrotic syndrome?
It's one of the other causes. So we already talked about 3, right? Diabetic, minimal change, membranous. There is one that's actually the #1 cause of nephrotic syndrome in the U.S. It wasn't this way, but now it's the most common one. It's called FSGS. Have you guys heard about FSGS? Focal segmental glomerular sclerosis. And it's called FSGS because of the pattern of involvement of the kidneys. It's like a focal inflammation, and it's segmental. It happens in some glomeruli and spares others. And ultimately, this inflammation ends up replacing and destroying the glomeruli. And these patients, they may become dialysis dependent. In the boards, they love to ask association of FSGS with 2 diseases. One is heroin use. Another one is HIV nephropathy. I don't know if you guys heard about HIV nephropathy. So HIV patients can develop nephrotic syndrome from FSGS. And the other one is actually the one that they're gonna ask you is obesity. Obesity causes proteinuria, and when it causes proteinuria, it's related to FSGS. So that's the treatment is actually you need to lose weight. I have a patient who had it, convinced him to get bariatric surgery. He did it, and he's doing pretty well. The proteinuria it just went in remission. Okay, so those are the 4 most common. There are others. I'm going to mention this one because they may ask you. It's called membranous proliferative glomerulonephritis, MPGN. Membranous proliferative glomerulonephritis. And that one is associated with hepatitis C, virus infection. Have you guys heard about cryoglobulinemia? Basically, it's complicated physiopathology, but for the purpose of your boards, I want you guys to remember that Hep B gives you membranous, Hep C gives you membranous proliferative glomerulonephritis. And another disease association that I forgot to mention, I told you minimal change disease and non-Hodgkin's lymphoma. And I'm also going to remind you that secondary membranous can be seen in patients with solid organ malignancies, like gastric, breast. They can present with membranous as well.
Can you say that again? Secondary membranous is...
Secondary membranous can be associated with solid organ malignancies. Yeah. So, okay.
Okay.
So what kind of serologies you send? Let's say you have a patient with this severe protein in the urine. So I forgot to mention lupus. Lupus is a big offender, right? Lupus can cause both nephritic and nephrotic. When it causes nephrotic, it's a type of lupus called membranous lupus nephritis. So as you can see from what I've said, as you can hear from what I've said, membranous can be seen as a primary entity or as a secondary entity, secondary to different things. And one of them is rheumatologic disease like lupus. Lupus is a nasty disease in the kidney, but fortunately it's treatable, and we have pretty successful rates inducing remission of this disease. So when you have a patient with these massive amounts of protein, the doctors, they usually send serologies for lupus, complement levels, because it can be also reduced in some diseases of the kidney. We also send serologies for syphilis, hepatitis B, hepatitis C, HIV, and you're going to see very commonly when a patient comes with all this protein, the doctors, they always send this kind of blood work to find out what's going on. Okay. So how do you manage this patient?
Figure out what's causing it. Yeah.
And how do you figure that out?
Do all the laboratory tests.
What if all of them are negative? That doesn't exclude anything, right?
Right.
So we do biopsies. Mm-hmm. Yeah. So we do biopsy of the kidney, but not everybody's a candidate, because before I do a biopsy, I have to think about what am I going to do with that information. If I have a non-dependable patient, I don't even bother, because imagine if I start offering this person immunosuppressive medications. He's not even showing up, he's not doing what he's supposed to. You're not going to ever prescribe immunosuppressive drugs to this patient. So, and number two, you have to ask yourself if the patient is a good candidate or not. If the patient is on anticoagulation, let's say Plavix, let's say Dr. Ben-Zur put a stent and he's having a lot of protein. Dr. Ben-Zur calls me and says, if you stop the Plavix, he may die because of thrombosis of the stent. I'm not going to touch him, because if I do a biopsy on Plavix, that guy may die. I mean, there's no way I would do that. So, by the same token, if you have a patient with uncontrolled hypertension, you can't biopsy those patients because they bleed. That's a contraindication, a clear-cut contraindication for renal biopsy is uncontrolled hypertension. So, and again, the question would be, if the kidney function is still preserved, if the person is willing to take medications to treat these diseases, because the medicines are pretty tough to tolerate, and they may include prednisone. They may include prednisone and immunosuppressive medications like cyclosporin or tacrolimus, or it may even require medications like Cytoxan, which is in the chemotherapeutic agent drugs. So you have to discuss it with the patient. If we were to diagnose these kind of things, would you be amenable to do this? If the patient tells me from the beginning I'm not willing to take any medications, don't even bother biopsying this patient, because we don't do biopsy just to establish the diagnosis. We do a biopsy to establish the diagnosis and have a plan of care. And I always have these kind of conversations. And you have to select which patients you biopsy. It's got to be somebody without a coagulopathy. It's got to be somebody, without hypertension and in relatively good shape. Let's say the patient comes in with an open wound, unhealing or non-healing ulcer. Why am I going to biopsy this patient? A lot of the treatments is immunosuppressive medications. It's more a disservice to the patient to try to do that. Another relative contraindication is patients with amyloidosis. Amyloidosis can also present with nephrotic syndrome. These guys, they have a massive amounts of protein. You can be 20, 30. I saw one time a patient with 46 grams of protein in a 24-hour urine collection. He had amyloidosis. But you don't biopsy the kidney because amyloidosis is pretty vascular and it can cause bleeding. So when you suspect amyloidosis, you either do a fat pad biopsy or you do a lip biopsy, and that's a less invasive way of establishing the diagnosis.
And what like histologically would you see for that? That makes you
Red Congo. You know the red Congo?
Red.
The Congo stain, it's on H&E.
Yeah.
Okay.
Staining, and actually it's not on H&E. It's a different type of microscopy, but the stain is called red Congo,
Mm-hmm.
and it looks just the amyloid material lighting up.
Okay.
Let me see if I can see a picture.
But the diagnosis is made through the biopsy on that.
Right.
Why are we trying to do biopsies?
To
Biopsies, we're just trying to establish nephrotic syndrome.
yeah.
Right.
The cause of nephrotic syndrome.
If they want to do treatment, if they can do it.
Yeah.
How you distinguish if it's amyloidosis versus, I guess I should look up the stuff for amyloidosis.
I don't remember
See a
learning.
picture.
I think we skimmed over it. So just very distinctive cell pattern, or
Yeah.
Amyloid builds up in your organs.
okay.
It's an abnormal protein that's in bone marrow, but can be deposited in any tissue or organ.
It has a very strong affinity for the cellulose fibers.
Okay. Right. Main cause of restrictive cardiomyopathy.
Yeah, it's a nasty disease. It can cause heart failure, kidney failure, liver failure, diabetes.
Yeah, amyloidosis.
So when you suspect that, you don't biopsy those patients because this is how it looks, the material deposit.
Oh, okay.
That's pretty big.
Yeah.
Okay.
Yeah.
So yeah, so kidney biopsies, the take-home message is they're invasive. They have a 5% risk of complication, including bleeding, requiring transfusions, requiring embolectomy, requiring nephrectomy, and possible death. So we don't biopsy everyone, we just biopsy good candidates. And good candidate means not only to establish the diagnosis, but also if they're willing to take treatment.
So you really don't biopsy a lot of people, it sounds like, to fit all those parameters.
I really have to have a good reason. If the patient tells me I just want to establish the diagnosis, and I explain to them like this is risky. I mean, would you want a biopsy just to establish a diagnosis? At the end of the day, there's no contraindications for renal transplant. You know, at the end of the day, a lot of these patients they come to see me when they're already fairly advanced kidney disease, like GFR in the 20s or in the 10s. So what am I going to do? Even if I establish the diagnosis, what am I going to do to treat it? I mean, probably the damage is already done. However, in patients with unexplained renal failure or patients with an active, very active urine sediment or a rapid decline in the renal function, you have to biopsy them because the last thing you want to miss, like for Dr. Ben-Zur, let's say that he doesn't want to miss a LAD disease because he knows that that patient can die anytime. For me, nephrology emergency is to miss an RPGN, rapidly progressively glomerulonephritis. Those patients, they do very poorly if you don't diagnose them with a biopsy. Within 3 months, they're on dialysis. So those are probably the medical, legal, scary things in nephrology, like missing an RPGN. Yeah. Okay. Okay, why don't you read the next paragraph?
So we went over the lab tests, right?
Yeah.
Okay, the patient is informed of his diagnosis of nephrotic syndrome and the potential benefits and risk of kidney biopsy and looking for the etiology of this problem. Did we do this one? No. He consented and the procedure is done without complication. The results of the biopsy showed evidence of membranous glomerulonephritis.
So how common is membranous? I think it's the second most common cause of nephrotic syndrome. Yeah, and then it can be idiopathic or it can be secondary. The idiopathic, we have a test, available blood test, to diagnose those patients that can't get a biopsy. It was approved by the FDA like 3 years ago. It's called the anti-phospholipase A2 antibody, APLA2. And we treat these patients with a combination of steroids and calcineurin inhibitors. It's almost like the regimen when you have a kidney transplant, cyclosporine and prednisone. But there are other secondary causes of membranous, like I said, parasitic diseases, viral hepatitis, solid tumors, and sometimes some drugs like gold, penicillamine, NSAIDs, like I mentioned. What is the prognosis of membranous? So we divide them in thirds. Like 1/3 of the patients, they go in remission with no treatment. 1/3 of the patients, they need treatment and they respond very well. And another third of the patients, they go into end-stage kidney disease no matter what. And I have a woman right now that I try to convince her for a whole year that she needed aggressive treatment. She didn't believe me. She went to see another nephrologist. The other nephrologist told her, like, I agree with the other guy. You need aggressive treatment because you have a pretty nasty membranous glomerulonephritis. And in 1 year, her GFR has gone down from 85 to 29 that I saw her last week. And I showed her the progression of your kidney disease. I told her, like, listen, we've been kicking the can for a whole year. Once the kidney is damaged, it's replaced by scar tissue. There's nothing we can do about that. So it's probably going to end up on dialysis. But it's hard, you know. It's the best thing I can tell you guys is listen to your patients, advocate for them, but you're going to realize very quickly that you're not going to save the world. And that's one of the reasons why I didn't become a pediatrician, because I probably would have been miserable fighting with parents, and I realized that parents are the cause of the kidneys problems for the most part. So that's why I love being an internist. I tell patients, I inform them, and people make decisions. Sometimes the decisions are poor, and that's why we have a lot of patients going in dialysis. But sometimes even with good treatment, these patients, they progress and they become dialysis dependent. And the higher the proteinuria, the higher the likelihood for progression. So you guys remember what the normal level of protein in the urine is?
0.
Yeah, 0 to 150 milligrams. Like if you have greater than 400, we no longer call it microalbuminuria. We call that albuminuria or proteinuria. And the higher, the worse. So this person, when you guys started reading the case, he had 12 grams, so he had 12,000 milligrams. I told you that normally is less than 150. He had 12,000. He's in trouble. Okay, so he's informed of the prognosis. He started a course of corticosteroid in conjunction with cyclophosphamide. He will be followed by side effects, and I usually follow the proteinuria because that's how you assess response to these patients. Very good. Questions? A lot of information, right?
Mm-hmm.
Yeah, I mean, the most important thing in nephrology is the urine sediment. Tomorrow we can probably talk about the nephritics because it's a very long talk. The nephritic patients, you know, you look at the UA, and the UA, if you see a blind urine sediment, you think about ATN. It's just that simple.
You said blind urine?
Bland.
Oh.
Bland urine sediment, like no.
Bland. No.
Bland.
No.
Like nothing in it?
Nothing. Just like maybe some granular casts. That's consistent with ATN. But if you see RBCs and WBCs, you have to work those patients up. Because if you have unexplained renal failure with abnormal urine sediment, you better work the patient up. Because you may miss an RPGN, and RPGN is a nephrological emergency.
Can you have RBCs and WBCs in a UA but not have them in the sediment?
Yeah. I mean, when I say sediment, it's because you spin down the urine and you look in the microscope.
Right.
But these are all automated tests, so they're pretty good reporting. What happens is that most automated systems, when they pick up RBCs or WBCs, they go to an additional step where a lab tech is in charge of reviewing the urine sediment and reporting and making sure that the findings are consistent, congruent. And you can have those things for many reasons. You can have it because you have a UA, a UTI, or you can have acute interstitial nephritis. I'm going to talk to you guys about tomorrow. Tomorrow we can probably cover RPGNs, interstitial nephritis, and kidney stones, because those things are going to be asked on your board. And multiple myeloma. Remind me to talk to you guys about multiple myeloma because you're going to get tested on that. And but yeah, these cells, they're abnormal. If you have microscopic hematuria, you can have IgA nephropathy, or you can have bladder cancer, or you can have renal cell carcinoma. So we'll talk about those things, how to interpret the urine sediment. If you have pyuria, just pyuria, you can have a UTI, but if the urine culture is negative, it's obviously not a UTI, but it can also be related to interstitial nephritis. It can also be related to renal tuberculosis, because remember the the urine culture just grows aerobic organism. It doesn't grow AFPs. Yeah, so it becomes a lot very interesting. But as a nephrologist, I put a lot of attention to the UA findings. That's basically what I do.
You said a bland urine sediment would reveal
no protein, no cells.
So it would be not a nephrotic.
Yeah. Not a nephrotic. Yeah, when you see that, you think about ATN as being the cause. And I did that case so you guys understand that ATN is pretty prevalent. And based on the differential, it's probably the most common cause of acute kidney injury in the hospital setting. Very good. When's your last day, by the way?
2 weeks?
The 30th?
Are you still here?
Yeah.
Do you have anybody else coming this week? Or?
I think next week.
From your school or from?
I think they're DOs.
Yeah, from the DO program. Yeah, next week. The 21st, I think.
Yeah, Monday. 1 week from Monday.
Yeah. 1 week from today. Oh.
Yeah.
Any other questions?
No.
Not ones that need to be recorded.
Yeah.